Just to recap the normal physiological function before we go into the details. So I'll be starting off with the WHO Group 1, that is a hypogonadotrophic hypogonadism, which accounts for 10% of the cases. And I'll be dealing with premature ovarian failure. What's a new terminology for premature ovarian failure, which also accounts for 10% of the cases. Looking at hypogonadotrophic hypogonadism, the diagnosis is confirmed on the history and based on the tests from the anterior pituitary. That includes FSH, LH, and the growth hormone, the ACTH, prolactin, and TSH, which are found to be very low in hypo patients. When you look at the order in which they are reduced, the growth hormone deficiency is the most common, 90%, followed by ACTH deficiency, which occurs in 66% of the cases. The FSH and LH are of very low values in 65% and TSH 42%. The classical history you get in a hypo patient would be a sudden weight loss, strenuous exercising for Olympics, chronic prolonged illness, psychological causes, and hypothalamo-pituitary disorders. Of course, in some you get a history of cranial irradiation, head injuries, tuberculosis of the brain, or sarcoidosis of the brain. When you look at the clinical history in hypo patients, they come with a period of amenorrhea, 3 months, 6 months. You give a progesterone challenge of medroxyprogesterone for 10 milligram, they don't have withdrawal bleeding. Normally, a patient with adequate amount of endogenous estrogen should respond with the withdrawal bleeding, but you find that even after 2 weeks, she doesn't respond. So if you give them an OC pill, you find they get an endogenous, they have an withdrawal bleeding after an OC pill. That is because of the estrogen content, which helps to solve the problem. Looking at the gonadotrophins, basically we look at the FSH and LH, and the values are less than 5 international units. You look at the E2 levels are pretty low. So they come with periods of amenorrhea, no withdrawal bleeding after progesterone, low levels less than 5 international units, and low E2 levels, you diagnose it as a condition of hypo. Commonly, when a patient comes with amenorrhea, the first step we do is to do a pregnancy test and the hormonal assays, as I told you, and a positive withdrawal bleeding, which indicates anovulation and unopposed estrogen stimulation. This typically occurs in polycystic ovary. The most important thing of hypo patients is do not prescribe clomiphene citrate or letrozole if it is available. These patients do not, because they have a low level of estrogens. You find if you give clomiphene or letrozole, these are the group of patients you have to avoid giving these drugs. So the basic treatment consists of treating with GnRH analogs and gonadotrophins containing luteinizing hormone. The first drug which was used earlier was a pulsatile GnRH, and the rate of ovulation was more than 90%. And the guest and Dr. Roy Homburg has got good experience in pulsatile GnRH, and a cumulative pregnancy of 96% after 6 cycles has been used. But the advantage over gonadotrophin is the low rate of multiple pregnancies, 17.4. So we don't use pulsatile because no longer it's available in the market. We use the gonadotrophins for the type 1 hypo group of patients. And the drug of choice would be a HMG, which contains 75 units of FSH and LH. If you are so particular about recombinant FSH, you can use recombinant FSH, but use a recombinant LH also to increase the cost and reduce the couple's bank balance. HCG, a dose of 50 units. If you don't have LH, or if you want to reduce the cost, a HCG given in a dose of 50 to 100 units will also serve the problem. The clinical success rates of HCG therapy in hypo patients, according to these authors, is 56%. And 14 studies, when the results were studied, a cumulative pregnancy of 89% after 6 cycles and 72% after 6 ovulatory cycles has been reported. Mind you, the multiple pregnancy rate when you use HCG in high doses is on the higher range in the tune of 30%. After that, we go to the second topic, hypergonadotrophic hypogonadism, the previously known as premature ovarian failure. If the FSH and LH levels are elevated, so you give a withdrawal bleeding with an OC pill and you check the FSH and LH and you find that they are elevated, you diagnose it as a condition of hypergonadotrophic hypogonadism, otherwise known as a premature ovarian insufficiency. It is related to the absence of inhibitory signals that originate from the ovary. The ovary doesn't contain follicle, there is no feedback, and you find that the hypothalamus pituitary axis, there is a lot of FSH and LH secreted to stimulate the ovary, but there is deficiency of follicles. The new term coined for hypergonadotrophic hypogonadism is premature ovarian insufficiency. It is a better description of the condition and carries a negative connotation that ovarian failure can cause great distress. You tell to a patient that you are having ovarian failure, just like a cardiac failure, she goes into a state of depression. So tell them you are having premature ovarian insufficiency. That is a new term which has been coined and reported in the Clinical Endocrinology of 2008. Diagnosis of premature ovarian failure or insufficiency would be, you do a day 2, day 3 FSH, raised FSH and LH, similar to menopausal values, ultrasound showing absence of the primordial follicles, E2 levels are pretty low, and when you do a karyotype, you find they have only one X chromosome instead of 2, or they may have associated chromosomes. So karyotype is mandatory if you are dealing with POF or premature ovarian failure or primary ovarian insufficiency. Looking into the terminology a little bit, there is a terminology known as occult primary ovarian insufficiency. A patient comes to you for IVF, it is an unexplained infertility. You do a basal FSH, it's normal. You stimulate these patients, but you don't get adequate number. You just wonder why these young patients are just giving 3, 4 or 5 follicles. You expect them to produce more than 10 follicles. This is an occult primary ovarian insufficiency which you have to keep in mind. They have a normal FSH, but the response to gonadotropin is very less. We have another condition known as an overt primary ovarian insufficiency, where you find that basal FSH levels are raised and they are associated with menstrual disorders such as oligomenorrhea, polymenorrhea and metorrhagia. So two of the terminologies I put into your attention is occult primary and overt primary, and the third terminology which we call as a premature ovarian failure is an extreme state of complete exhaustion of the follicles. So we have primary ovarian insufficiency, otherwise previously known as premature ovarian failure, where there is follicle depletion, and the follicle depletion is the main pathogenetic mechanism in POI or POF. It may be due to a low initial number of follicles. It can be due to an accelerated follicular atresia. It can be due to autosomal anomalies. The second cause of a primary ovarian insufficiency is due to follicular dysfunction. The normal oocytes that fail to grow and ovulate in presence of elevated gonadotrophins. So the primary ovarian insufficiency, the cause can be multiple. Patients coming with premature ovarian failure or primary ovarian insufficiency have unremarkable clinical findings. You find they are short-statured, web neck, bow elbows. You are dealing with the case of Turner syndrome. Or you have the patient coming with bradycardia, tachycardia, goiter, exophthalmos. It can be hypo or hypothyroidism. Or you have clinical signs of adrenal insufficiency like orthostatic hypotension, hyperpigmentation and decreased axillary and pubic hair. So it could be adrenal insufficiency you are dealing with. They may have autoimmune disease which presents as vitiligo. When you do a pelvic examination, you find because of the lack of estrogen, you are dealing with atrophic vaginitis, and they have some spotting also associated. There is a whole battery of investigations recommended for primary ovarian insufficiency. We commonly go for a FSH, LH test and a karyotyping. And test for fragile X chromosome mutation has been recommended in this group of patients. So the main lab investigation would be to measure the serum FSH level and measure the serum LH level. And even if you go without estimating estradiol levels which is low, it is fine. Karyotyping should be performed, and genetic counseling and testing for FMR1 premutation is necessary. Coming to the treatment of hypogonadotrophic hypogonadism, estrogen replacement therapy has been advised. It's a long term until the normal age of menopause. They should be fully counseled about the benefits and risk of hormone replacement, and long term follow up is required. Estrogen therapy to prevent osteoporosis, relieve hot flashes and other symptoms. Calcium and vitamin D3 for preventing osteoporosis. Mind you, estrogens can be administered continuously or cyclically. 21 days estrogen, 7 days off, because there is no controlled studies comparing efficacy of one over the other. Estrogen therapy can improve the chance of pregnancy by theoretically lowering the LH levels to normal range. So on estrogen therapy, they have a chance to become pregnant also. It can be administered orally or transdermally, and twice as high as recommended dose. So if the woman twice as high as recommended dose for the women who are postmenopausal has been recommended. So estradiol you give 100 to 150 in hypogonadotrophic hypogonadism. For HRT you give only 50, and conjugated estrogens, if you are in a dose of 1.25 in premature ovarian failure is recommended, whereas HRT you may give 0.6. So twice as what you give for HRT has been recommended. Progestins of course should be given cyclically to prevent endometrial hyperplasia, and the drug of choice will be medroxyprogesterone for 10 to 12 days in a month. Androgen replacement considered for persistent fatigue, low libido, poor well-being. Despite adequate estrogen replacement, you find that the symptoms persist. Think about androgens. Of course, calcium and vitamin D, 1200 to 1500 milligrams of elemental calcium should be there in the diet. Think about donor eggs. The prognosis of women with spontaneous is low. Approximately it is said that 5 to 10% of the patients with premature ovarian failure or POI will become pregnant. I have not seen any patient in my whole lifetime, but literature tells 5 to 10% becomes pregnant. The ovum donation remains the best option to resolve the fertility, and the patients with premature ovarian failure or ovarian should not be encouraged hastily, because they should be advised that you have a 5 to 10% chance to conceive, and the real possibility will be ovum donation, and it is successful in older as in younger. Always tell the patients with premature ovarian failure to look beyond. You have to ask them to look beyond. So the hormonal replacement therapy, ovum donation and other benefits should be explained to them in detail before you tackle and say them goodbye. Thank you.